Okay, you guys, let's get started. I'm just going to be looking at my blog, and I'm going to be just basically reading uh, these flashcard clinical vignettes, which I downloaded. I bought from Amazon. And these are the Lang pharmacology flashcards. So I'm just reading them, and so if this can be really boring for you, this is your time to bail out. Anyway, we're talking about the endocrine system, and first we're going to talk about insulin. So I'm reading them just to familiarize myself with them, and so they may stick in my brain. Okay, synthesis. Synthesis of proinsulin is broken down into insulin and C-peptide in the pancreatic B cell and in the beta cell of the pancreas. And remember that the beta cells secrete insulin, and the alpha cells secrete glucagon. So secretion of insulin glucose binds to a receptor on the pancreatic beta cell and is taken up into the cell. In the beta cell, glucose is oxidized and ATP is formed. ATP binds to a calcium channel and inhibits the flow of calcium into the cell, leading to cell depolarization. Cell depolarization leads to the release of intracellular calcium, which stimulates insulin release into the blood. Insulin then travels into the liver, muscle, and adipose tissue, where it binds an insulin receptor in order to exert its effects. So the actions of insulin: it decreases blood glucose levels by decreasing hepatic gluconeogenesis, including glycogen synthesis, and increasing glucose uptake into cells. It inhibits lipolysis, stimulates amino acid uptake into cells, and decreases serum calcium levels by increasing calcium uptake into cells. So synthetic insulin preparation. So we have these types of insulin: fast acting, regular acting, intermediate acting, long acting. And as I explained in a separate video, these insulin preparations are given. These are for type 1 diabetes mellitus, and for type 2 you can take an oral form. And that's explained in a different video. So let's look at insulin lispro. So there's a rapid onset of action, peak 1 hour, very short acting. And then regular insulin, and the rapid onset of action is peaking at 2 to 3 hours. And you might think of regular insulin such as Humulin. Then there is a semi-lente insulin, which is sort of intermediate acting, and then lente, meaning this is is intermediate too, and then there's the ultra lente, which is the slow onset of action. So let's start with our first case. A 59-year-old woman presents to your endocrinology office for a follow-up of her type 2 diabetes mellitus. She tells you that she has difficulty achieving optimal control of her blood sugar. She currently takes Metformin. Her hemoglobin A1C level is 7.7, and this is an indicator for type 2 diabetes, indicating that her glycemic control over the past 3 months was not ideal. You decide to add another medication to the Metformin that will lower her blood sugar by stimulating increased insulin release by the beta cells of her pancreas. So this is a classic case for sulfonylureas. So the MOA here is they stimulate insulin release and prolong the binding of insulin to the target tissue receptors to reduce the serum glucagon levels. Side effect here: hypoglycemia. So remember this side effect. And it is contraindicated for people who are pregnant, and it should be used in caution for patients for patients who have renal or hepatic insufficiency. So these are very important to learn for your test. The contraindications: pregnancy or renal and hepatic insufficiency. So going on, next case, a 40-year-old A 48-year-old male presents to his primary care physician's office for an annual checkup. He reports that over the past few months he has noticed that he has been thirstier and has been urinating more frequently. His family history is significant for type 2 diabetes in both of his parents. A fasting glucose level is 52 milligrams per deciliter. All other laboratory studies are normal. You tell the patient that he has type 2 diabetes and you decide to begin him on medication that will lower his blood sugar by inhibiting glucose production by the liver. This is another classic case. This time it's for Metformin. So this is part of the biguanides family, and it inhibits hepatic gluconeogenesis, increasing the peripheral utilization of glucose. So it's different than the sulfonylureas, and it is non-insulin dependent type 2 diabetes, and the side effect here would be GI upset or acidosis. Again, so it says here it's contraindicated in patients with renal insufficiency, but it does not cause hypoglycemia. So how are you going to recognize on this on a test? So this is different from sulfonylureas. How? So here they mention the hemoglobin A1C level, and it talks about the beta cells of the pancreas that will be stimulated to produce more insulin. But here it's talking about lowering the blood sugar by inhibiting glucose production by the liver. So those are your key words here. So moving on, I'm not going to get so deeply into the MOA, but just to recognize the cases. Oops. Okay. A 62-year-old male presents to your office for follow-up of his type 2 diabetes mellitus. He is currently on metformin, glipizide, and rosiglitazone, which he takes regularly. Despite his medication regimen, he attempts to control his diet. His most recent hemoglobin A1C is still slightly elevated at 7.5%. So if it's at 6, you're going to worry about it. He states that he would like to avoid insulin if possible, but instead ask you about a drug that he saw in a commercial on TV that treats diabetes by mimicking glucagon-like peptide 1. So these are the meglitinides. So they bind the potassium channels, which is different than the binding sites for the sulfonylureas on the beta cell, which stimulates the release of insulin from the pancreas. So how can we understand what the differences are? So if you can see this, so the meglitinides here, they are similar to the sulfonylureas, that they increase the insulin secretion beta cells from the pancreas, and they force the insulin out of the blood and into the cells. So one difference here would be the side effect, so weight gain and hypoglycemia. So try to recognize these keywords here. Okay, moving on. A 42-year-old woman presents to your clinic complaining of weakness and fatigue over the past month. Physical examination reveals areas of hyperpigmentation over her knuckles, knees, and elbows. Initial laboratory studies demonstrate hypoglycemia, hyperkalemia, and hyponatremia. You decide to order several other lab tests, and you begin to suspect that a condition may be due to an autoimmune process, that you will likely need replacement therapy of several hormones to treat her symptoms. So this is a case for prednisone, and this corticosteroid is synthetic corticosteroids, prednisone. I'm getting confused here. We're talking about an adrenal cortex problem where the communication between the ACTH and the adrenal cortex is causing some difficulty with the production of cortisol, and we're seeing the problem as shown in the case. Is it Addison's? Is it, if it's not Addison's, is it, hold on 1 second, I'm getting confused here. Okay, I was just trying to figure out whether it was Addison's or Cushing's disease or some Cushing's degree syndrome, but at least we should notice the case here and know that it's prednisone that is needed in order to, if it's some inflammatory process or some immune process that needs to be taken care of, prednisone here is what is needed. So this mimics the actions of the endogenous glucocorticoids and side effect symptoms of Cushing's syndrome, osteoporosis, irritability, hyperglycemia, fat redistribution, and impaired wound healing. So some of the classic symptoms of Cushing's disease. So this is used for prednisone for adrenocortical insufficiency, collagen vascular disorders, lupus, polymyositis, asthma, spinal cord depression. So be able to recognize that this would be a case for prednisone if there's a choice. Okay, moving to the next case. Let's do one more case, then we might close off this video and open a new one. Okay, a 45-year-old man presents to the ER complaining of large volumes of bloody vomit. His past medical history is significant for cirrhosis secondary to alcohol abuse. Physical examination is significant for heart rate of 100 beats per minute, blood pressure of 90/60, and some epigastric pain. You call the gastroenterology service for an endoscopy which demonstrates the presence of several esophageal varices. You start the patient on a synthetic analog of naturally occurring pancreatic hormone, which causes vasoconstriction and esophageal varices. Vasoconstriction of his esophageal varices. So this is octreotide. Octreotide is used for endocrine disorders to reverse this hyperthyroidism. So it is similar to somatostatin, and the MOA is the synthetic analog of the hormone somatostatin. So treatment of a variety of endocrine disorders, acromegaly, treatment of esophageal varices associated with cirrhosis-induced portal hypertension. But when I look at this, I'm thinking of octreotide is used for gigantism or acromegaly, and I need to recognize this here is for cirrhosis secondary to alcohol abuse. Well, this may be one I just have to remember. Anyway, I'm going to close off this video and I'm going to open a new one, part 2. Thank you very much.